Hi, my name is Dr. Toby Morma. I'm a family physician, assistant professor at the University of Mississippi Medical Center, and it's a joy to ask you to join us on our show, Health and Wellness with Dr. Toby. This week, we have a great guest. His name is Dr. Femi Ogundeji. He's an addiction psychiatrist at the Brentwood Hospital of Psychiatry in Shreveport, Louisiana. Been with them for 6 years, trained at the University of Ilorin, Nigeria, Drexel University for his psychiatry residency, and then went on to do 2 years of addiction psychiatry. He's one of the few addictionologists in the state of Louisiana. He's going to be sharing his experience treating gambling, treating sex addiction, treating cocaine abuse, treating marijuana, ADHD, stimulant abuse, treating children, adults, pregnant women. He has a multi-specialty experience, and you don't want to miss it. Look forward to seeing you on the show. Jesus is Lord. God bless you. My name again, Dr. Toby Moma, your host on Health and Wellness with Dr. Toby. God bless you. Hi, this is Dr. Toby, your host on Health and Wellness. It's a pleasure, it's a delight to have you on our show today. With me on the show today is Dr. Ogundeji. Dr. Ogundeji is a board certified psychiatrist. He's also an addiction psychiatrist, trained at University of Ilorin, Nigeria. Went on to do his residency at the Drexel Hospital in Philadelphia. Got his MPH in Masters in Public Health, and he also underwent addiction psychiatric fellowship at the Bronx, Lebanon, part of Albert Einstein in New York. And he's here with us today. He's been working in Louisiana for a couple of years. How many years have you been working here?
6 years.
6 years. So he's an LSU fan, I'm sure. By now he's like well integrated into the community. And you and I know the scourge of addiction in our society. And I wanted to bring an addiction psychiatrist who specializes in the bane of this, the biopsychology. We want to know, is there actually a biological explanation for addiction? I mean, is it just people come out and say, oh, it's just his demons or just his, father's demons? Is there a biological explanation for addiction?
There is, and we pay special attention to that when we see patients. Taking family history, because studies have shown that there are genes associated with addiction and is hereditary. That's why you found out that this runs in families.
Okay.
And people are at higher risk. We see it as a 50% nature and 50% nurture. People have a higher, some people have a higher risk of becoming addicted because of some genes they inherited from their parents.
Now, we know in America, the studies from the CDC say possibly 1 in 4 Americans or 1 in 5 Americans is dealing with addiction or substance abuse of some sort. I mean, substance abuse includes marijuana, does it include alcohol?
Yes, alcohol.
Does it include cigarette? No.
Yes.
It includes cigarettes too?
Yes.
Okay. So 1 in 4, or 1 in 5, that's a huge number. What do you think is responsible for the upsurge? Because I think they said in the last 10 years, the number of deaths from substance abuse it's even higher than from cancer. That's what we're hearing. I think they say like a Boeing 747 crashes every 30 minutes or something, from what I heard, due to substance abuse. And a Boeing 747 takes about 247 people. So we are living in dire straits in the world of addiction. So let's try and identify what is the cause of this upsurge. Has something changed in America that caused an upsurge recently in this?
One, there's more availability of drugs, and especially some of these newer drugs we call designer drugs are made more pleasurable and presented to the younger population. Like you find out that kids are not smoking cigarettes, they are vaping these days. You find out there are something like kratom flakka that you can get on eBay, you can get in corner stores, and people abuse these things. And also the society, the way we are raising up kids, most homes are single homes where parents are busy to meet the demand of the home. The kids are left to raise themselves. You find that peer pressure in school, and most of the people who start drugs usually start with things we call gateway drugs in middle school. As early as fifth grade in elementary school, you see kids.
What are these gateway drugs so that we can know and be aware of them in our community?
Gateway drugs are drugs usually that are very easily available in the community that kids can get to. An example that we don't even pay attention to now is the inhalant. Things like dust cleaner, nail polish removers, and those are also the types that this kid gets owed to. Even gasoline from the car. People could abuse that, they sniff that in and all that. Cannabis, because of the way the society looks at it, a lot of people these days
That's
don't see,
marijuana.
yes,
Right.
they don't see it as a problem. They just think it's a natural product God created for us to use. And you talk to parents, I don't see a problem my kids smoking marijuana, when we've seen people who had episodes of psychosis following marijuana use. But so those are some
And
of
it
the
opens the gate to the more lethal.
Yes, because for these kids, their brain are still developing in the teenage years. So when it's exposed to drugs, the part of the brain that controls the urge to use drug gets activated and wants more and wants more. And a lot of them are very curious, and then they start trying things, and the internet is there for them to know more about.
Can you tell my viewers what are the side effects of the drugs? You can name them one by one if you choose to, but in terms of psychological effects of marijuana, alcohol, cocaine, heroin, what are the signs and symptoms you see when somebody is abusing those substances of abuse?
Usually, with substance abuse, when you use drug, it affects you as it affects you totally. It affects your physical health, your emotional health, your finances, your relationship. You find that kids who are very good in school, all of a sudden they lose interest in academics. They go into their room, you think they're doing their homework, they are getting high and passing out. You find that their grades start dropping. You see somebody who works, start call a very good worker, start calling off or work because they are either going through withdrawal symptoms because they can't get the drug, or they are feeling sick, having hangover. It has a lot of effect on the liver, the kidneys. These are part of the organs in the body that breaks these drugs down. And you find out the brain too makes a lot of changes in the chemical that regulates or balances out our emotions. You see people start seeing things, hearing things. People don't care about how they look. You see a 24-year-old would not shower, their teeth is rotten and all that. And then it affects our sleep as well. You find out they depend on this thing to sleep at the end of the day.
Wow, interesting. So the whole mentality of substance of abuse is to feel good. That's the motive of the abuser. They want to get a high. They want to feel like they're out of this world. Is that the reason they start taking more and more of this?
There are different reasons why people take more and more. The first thing I've seen is that in our society, a lot of people shy away from psychiatric problems. Some people are having symptoms of anxiety, symptoms of depression, family is not listening to them, parents don't want to be labeled. And they find out that maybe with my anxiety, when I drink or abuse things like Xanax or some controlled substance, I feel relaxed. They begin to use that. Some people, they have no coping skills. Life has always been very, very good. When they feel traumatic event or difficult situation, they find it hard to adjust. And some people, with studies have shown that, especially with women, about two-thirds, 2 out of every 3 women in substance abuse treatment has experienced one form of trauma, emotional, physical, sexual, which in our society we don't really talk about. And then they just start numbing themselves. And the way God created our body, that it gets used to a drug after some time. They don't feel the way they used to feel. If a glass of wine makes you sleep at night, over time 3 glasses will be enough. Then you just keep consuming more just to chase that feeling. And some people just don't want to have any emotions, so they use that to numb themselves.
You know, as a physician, I'm surprised that in 2019 the CDC came down with this pain management protocol, which I support totally. But it's almost a paradox because 5 to 10 years ago, almost every state in America began to legalize marijuana. So here we are 10 years after opening the gate to marijuana, telling everybody we have a drug dependency problem and we should stop giving out opioids and, fentanyl and benzodiazepines, which I agree with totally. My question to you is there a relationship between the legalization of marijuana and the upsurge in the use in the substance abuse epidemic, and not just the but in the mortality of people who abuse substances? Like I said earlier, we have more people dying from substance abuse than from cancer, heart disease, and stroke combined in America every year. More people die from substance abuse. So when did this happen? Were we blindsided? Has it always been like that? Or was there a correlation with the legalization of marijuana? If I remember correctly, I think we had the first legalization in maybe 2009 or 2010. I cannot remember totally. But that's my question. Is there a correlation?
There might be some link, but I don't think there's actual studies that says the legalization of marijuana led to increased substance use or opioid surge. Because speaking to some of these patients who are addicted to opiate, many of them have not tried marijuana. I just think it's the way we were very liberal with the prescription of opioid. Somebody go to a dentist to have a teeth extraction, the dentist prescribe a month's supply of opioid, which actually a week might be enough. And what I can take from the 1 week prescription, the 7-day prescription, is that it helps monitor the progress of the patient. I've seen a lot of people get a month's supply of opioid after surgery because of the quantity they have. They don't even remember if they've taken one in the morning, then they take another one. And the more they take, the more they begin to like it, then the chances of abusing it. And then people get so used to it that it helps them get out of bed and they feel good when they are still healing. Then they do more than they should do, then they have more complications from the surgery. But if you're giving somebody a 7-day supply, that doesn't mean you are going to stop it at 7 days. You reevaluate the patient after 7 days. If a patient has just maybe 10, 15 pills, they will take it as prescribed rather than a whole bunch of pills. So usually you reevaluate them. How is the pain? Is the wound healing well? And then you can maybe give them a lower strength for another week and you taper them off that way.
So as an addiction psychiatrist, sorry to cut you short, what would you tell doctors and dentists in light of the risk of using opioids beyond? What's your recommendation?
I would still stay with prescribing 7-day supply and reevaluate their patient.
Okay.
And also take a good family history when you're talking to patients. Some people will tell you, my father had opiate addiction, my mom has opiate addiction. Those at higher risk of becoming opiate dependent. So you give them the options of non-controlled substances. With pain management, you can give them a few pills of this and use the non-controlled substances for breakthrough pain. Okay. And there have been good results with that.
Can you tell us what is the age you see the highest level of addiction or narcotic dependency or drug abuse? Is it in your teens? Is it in your 20s? Or is it in your 50s?
There are two sets of peaks. One, those who use more of street opiate like heroin and all that, fentanyl patch, fentanyl coming in from other countries, are the younger age group, early 20s to their 30s. These are the workforce who just want to get strength to do what they can't really do.
Strength?
Yes. People will tell you they use opioids and they have strength to clean, to load, and all that.
Really? So it makes you feel sleepy.
It makes some people feel sleepy, but some people it gives them the opposite effect. Okay. And then they go around doing things they can't do. And we have the geriatric population that have had one pain problem or the other when younger, and they've been on prescription opiate for 40, 50 years, and they just go and get their refills and get their refills. And because of tolerance, their body needs more and seems they are abusing it. And one thing I tell most of my patients, at times they don't want to use the opioid, But when they try to cut off on their own, they go through withdrawals, and one of the symptoms is pain. So they think it's their back that is really hurting,
Oh.
then they go back to it. So usually we do the detox. After detox, then we reassess their pain. And many of them are like, I'm fine, I don't have any pain anymore.
Tell me about that hyperalgesia effect because I think it's a difficult thing to understand. You just mentioned it. How in the middle of getting pain medicines, you stop and then I think it gets worse when you keep taking it,
Yes.
right? The hyperalgesia effect.
Yes, because your opioid receptor are so used to
Okay.
the pain pills, and they don't really work as well, and then you get so very sensitive to slight pain, and then because you're used to numbing yourself to pain in the past, any slight pain is like discomfort to you. You see somebody will tell you their pain is 10 out of 10, but they can still sit down and talk and chat with you. It's just that part of the brain that just don't want any feeling of discomfort.
How do I handle a hyperalgesia? So I'm trying to withdraw her, and she's okay. She's taking more and more. She's increasing her dilaudid from 1 to 2 to 4, and the pain is getting worse. What do I do?
If they've been on the particular pain medication for a long time, it's always safer to switch to a long acting, and then they might be more sensitive to that one, and with that one you can slowly cut them off over months, and let them have, while you're doing that, you titrate with some non-controlled substances.
What do you use in your clinic for withdrawals, or let me use the word tapering off? When a patient has been an opioid dependent, needs to taper off, needs to come off it, how do you taper off, and what do you use in your
It depends
practice?
on what the patient wants. Their inpatient setting, which is usually
So
very rapid.
60-year-old executive in a multinational company, he's a functional independent, but he knows he's dependent.
And he doesn't want to come in for detox.
He
or
doesn't want to come in for detox.
Usually, what I will ask them to do first is to work with their provider, their pain doctor, to start cutting the amount of pain pills is given them, and try something else to help. And like gabapentin, Cymbalta, NSAIDs.
Is it worth changing him to extended release?
It's worth to change it from immediate release. Immediate release are not so good for chronic pain or long-term pain management. Because of the short duration of action, they tend to take more and more. And anytime the level drops, they have more pain, which is withdrawal pains rather than just the real pain they have. So switching them to extended release might be an option, and you see how they get, if they get a better control. And also, provider trying to not give a month's supply at a time, or 90-day supply of pain pills can help. I've seen people, for example, somebody with sickle cell who have maybe arthritis with it, or would definitely need pain, pain medication, but they get used to it. So rather than giving them a month's supply, you might just do a week's supply with refills every week. So when they see there are very few pills, they can monitor what they take compared to when they have a large amount of pain pills.
You have a unique medical angle to this because you're a psychiatrist and then you're also an addictionologist.
Yes.
Do you see any correlation between the dysfunction in homes and drug dependence? So when you see a post-traumatic stress, anxiety, depression, bipolar, can you connect it with drug dependence?
Yes. I always tell most of the patients I actually see are dual diagnosed patients, those who have psychiatric problems and addiction problems. Unfortunately, it's like the story of the chicken and the egg, which one came first. Some people started with substance abuse to deal with life stressor, which precipitated a psychiatric problem. And some people have undiagnosed psychiatric problem they are trying to find solution and help with, and they are beginning to abuse drugs. And one thing most parents, family members don't understand, they just feel they can wish the addiction off. If you don't treat their comorbid psychiatric problem, which might be the reason why they are using drugs. Somebody who is manic or bipolar, who has racing thoughts, can't still to sleep. We use downers like benzos or alcohol to sleep. Somebody might tell you, I get angry easily until I smoke cannabis. Somebody tells if they close their eyes, they have dreams about previous trauma, being raped. And if you don't get them the counseling, the right medication, they'll keep relapsing. And people are like, you've been in treatment 12 times. Why are you coming back? Until the primary problem is addressed.
Wow, that's pretty impressive. Just tell us a little bit of how the church can help. A lot of my viewers are pastors, and you mentioned something in the earlier segment. You said our society does not like to talk about psychiatric issues, and I think the church is a culprit in that. A lot of churches don't want to address depression, anxiety, even addiction. I think I was in church once when a anesthesiologist in my church became, unfortunately, dependent on the drugs he was given. And suddenly everybody in the church cut him off. I think he lost his license and he was, but it was just almost overnight. He was respected one day, he was shunned the next minute. But your opinion, what can the church do to improve her response to people in the church with substance abuse?
The main problem with the church, I'm a Christian too, but what I've seen with churches is that they don't want to associate with substance abuse and psychiatric problem. Many of the churches believe it's more of a demon-related problem rather than a medical or psychiatric problems that has solutions to it. I've had programs that are very, very good who takes care of patients for rehabilitation, faith-based program. But the problem with some of this program, which I've been trying to find ways of getting to them and educate them, they take a lot of patients, but they will say you can come in with your medication for medical problems like diabetes, seizure, hypertension. But if you take psych medication, you can't come to the program except if you stop taking your psych medications. So a lot of people are really interested in the program. They've seen the success rate. They send people down there. They throw away their psych medication. In few weeks, somebody starts hallucinating. They send them back to us. So the church just needs to open up. There's a problem in the society. Studies have shown that 1 in 3 person in the United States has something to do with addiction. Either your family member, your spouse, your co-worker, or you treating somebody who has addiction problem. It's really a problem. The issue of stigmatization, how will the church know if my son is found to be abusing drugs? It's something we should open up to and talk. And even with some of the treatment for addiction, which is the Alcohol Anonymous, Narcotic Anonymous, they all believe in higher power. And some churches are beginning to open up to it, things like Celebrate Recovery, where people know that they have problem, God can help them through, and they are not shying away from it.
And Teen Challenge,
Like,
I think.
yes. But the problem is the church is really, really a problem they don't want to discuss, but it's within the church. It's a problem that is within the church.
Do you believe that we have a problem with international drug dealers? Some people make excuses. I'm sorry to say. They say, oh, this is because people from Mexico or Colombia or I don't know what other country are bringing drugs into my... they make it look like other people from other countries are the ones causing the problem.
I don't think so, because many of the drug barons are U.S. citizens. They just use those local channels to bring it in.
So it's a reality that people bring drugs in through mules or all kinds of means. It's a lucrative business.
It is a very lucrative business. And that is one thing I always tell people. Those people are business minded. They are not looking at your interest. They cut these drugs with anything just to increase their profit. They add different things to the drugs.
Right. And obviously now it's an international problem because all over the world we have this issue. What do you do in the state of Louisiana? Obviously you're a Christian and you walk by your spiritual morals and ethics. How do you handle, because people come to you and say, I want marijuana. I know the state of Louisiana recently approved it. So how do you handle that? How do you, are you,
Being an addiction
you don't
psychiatrist,
get those patients?
I get them.
Okay.
I do general psychiatry as well, and I don't argue with you. I just explain my own stand that I believe medicine is so structured that most medications work for one or two things. If you take diabetic medication, it works for diabetes. It's not going to work for arthritis. But when they tell you marijuana works for 20 different things, I think something is not right there. You take high blood pressure, you can use that to treat your high cholesterol.
Yeah.
But when you tell you have seizures, you have pain, you have PTSD, you have nausea, you have everything.
Glaucoma.
Glaucoma, one drug cannot really treat. And I would rather say until you've tried everything
Right.
possible at adequate doses and it's not working for you. And some of them will cry in my clinic and say, you have to refer me. You can request for your record, but I can't say you failed my treatment because there are still
You
options
haven't
for
even
you.
started.
And
Right.
some of them will go 2, 3 months, they will come back and say, they don't work. I'm like, I know it wasn't going to work. So
Interesting. So we've been talking with Dr. Olufemi Ogundeji. He's an addiction psychiatric at Brentwood Hospital in Shreveport. And he's been living here in Louisiana for 6 years, trained in some of the best institutions. And he's been sharing his heart with us on addiction. We're going to continue this discussion next week. You don't want to miss it. If you have a loved one who's on drugs and who you think may have a dependency on drugs, alcohol, cigarettes, marijuana, heroin, cocaine, opioids, any one of those above, fentanyl patches, crack, you need to hear what he has to say. We want him or he or she delivered. I believe that as we speak the words through the television screen, your loved one can be delivered. I want you to write to me. My P.O. Box is 550 West Monroe, Louisiana. 550 West Monroe, Louisiana, 71294. Write to us at Faith and Power Ministries. We are here in the local area. We have our monthly Holy Ghost night. The next one will be on the 20th of November. But we're looking forward to seeing you there. It's going to be a powerful time in God's presence. The venue is Oyo Hotel on 165, 11 p.m. to 4 a.m. I'll be ministering, and there'll be guest ministers along myself. We're preaching, we're prophesying, and we're praising God. As we clean out this year, don't wait. Let God intervene, because the last has been saved. For the best has been saved for the last. In Jesus' name. God bless you. Look forward to seeing you next time. In Jesus' name.